in the body that is a barrier to malignancy. You get a cancer, but you seldom get a cancer invading into that tissue. Oh, and by the way, the cornea is avascular and so is this other tissue. Any ideas? What is the other major tissue? Huh? Which? Did you say cartilage? I think you said cartilage, yeah? Hyaline cartilage? If you didn't say that, that's a wonderful answer, okay? Yeah, you can... You know, my hearing also goes with my vision. Also with my age. Okay, so let me just tell you, you can get chondrosarcoma, but it's well known in pathology, you seldom get a malignancy that invades into hyaline cartilage. Hyaline cartilage is avascular, so is Bowman's layer. Which, by the way, gets me back to another point of general pathology. Remember I said that pannus, degenerative pannus, is only one type of pannus. There's another type of pannus, we call it inflammatory pannus. What is the pathology of inflammatory pannus? I mention these things because you never know that in the next 15, 20 minutes, the next hour or so, you may actually see some of these things. It's okay? I'm preparing you for some other adventures in ophthalmic pathology. In inflammatory pannus, see if you can picture this, imagine this. You see a fibrovascular membrane that is packed with lymphocytes. And in contrast with degenerative pannus, which just sits there as a membrane on the top of the cornea, degenerative pannus destroys Bowman's layer. And now you have another analog with hyaline cartilage. Because what I have basically described to you, if I told you that on the top of hyaline cartilage I had a fibrovascular membrane with lymphocytes that destroys the cartilage, you would say, it's the joint rheumatoid arthritis, yes? You have the identical pathology in the cornea's inflammatory pannus. Really wonderful. It's enough with Bowman's layer. It's okay? You have questions about Bowman's layer? No? So let's go back and identify the limbus. By the way, for those of you who are following, I always will keep up on the upper right-hand corner where I am so that we can see orientation-wise. So at the termination of, we don't need a wireless network here, at the termination of Bowman's layer, which doesn't have a name, I'm going to put an arrow. If I will turn down the magnification a bit, now let's look at Descemet's membrane here. A couple of interesting things you can see about Descemet's membrane, back here, is that at the very periphery of Descemet's membrane, I'm going to trace it. Look. You see? It's not linear. It has many bumps. Now that I have drawn it for you, I will take it off. You can see it now, yeah? After I point it out to you. So what do you call these? If they were in the center of the cornea, what do you call them? The guta. Okay. If they're in the periphery of the cornea, they are associated, I don't speak about aging anymore. With every year, I speak more about maturity than aging. Yeah? Okay. So they're associated with aging, and we call them Hassel-Henle warts. And the periphery, it tells you that this is not from a young patient. This is from a more mature patient. Okay? And of course, so what do you call, what name do you put on the termination of Descemet's membrane? Whose line? Schwabe's line. Schwabe's line. So I'm going to put here another arrow on the back of Schwabe's line, like over here. Now let's bring the magnification down a bit. And I have my two markers, and I'm going to connect them with a line. You can see that the line is not very straight, which is a very good explanation for why I am not a surgeon. Huh? Okay, good. So you have a line here. This is the anterior limit of the anatomic limbus. The anatomic limbus, not the surgical limbus. Now, to find the posterior margin of the limbus, you need to find the scleral spur. Now, it turns out the scleral spur, and I know this morning that there are a number of, how many people in the room are residents training in ophthalmology? Do we have a fair number? Yeah? Okay, so I'm going to get a little bit basic for a moment. If I were to, I just gave you the answer to a very important question. If you were going to do gonioscopy, and you want to say, you want to declare 100% the angle is 100% open, the major gonioscopic landmark that you look for is the scleral spur. And the reason that you look for the scleral spur is if you see the trabecular meshwork and you don't see the spur, it's possible that you have peripheral anterior synechiae of the posterior aspect of the meshwork. It's okay? But if you see the scleral spur, the angle is completely open. If I am losing a bit of my pathology colleagues, please bear with me, I'll come back to you. There's a little bit of ophthalmic specific stuff here. Now, how do you find the scleral spur on a slide? And I was speaking over the past couple of days with Professor Perelman, Dean Perelman, and we were comparing, the trends in medical education is to do virtual anatomy. And both of us decided, both at Deathleon and our new medical school, you actually do dissection, you have to touch the bones to feel it. So you know that the bones, you remember from medical school, have tubercles, right? Projections. And tubercles are usually the sites into which muscles insert. Okay. So how do you find the scleral spur? Is you take the longitudinal muscle of the ciliary body here, and you trace it forward until it stops there. And we'll put another marker, the scleral spur. By the way, you can see here Schlemm's canal, and over here you can see trabeculum muscle. And the scleral spur, I will show you, becomes a very, very important landmark. So what I do is I now take and I draw another line that goes through the scleral spur, parallel roughly to, that defines the anatomic limbus. So on an examination, if you are ever asked to yourself, can you please identify the limbus for me? Histologically, you now know what are the landmarks. Now, we need to talk a little bit more about the scleral spur. And I'm going to ask, I hope that you don't mind that I will do this, I'm going to ask if we can turn the room lights up for just a minute. Can we make the room lights on? I will ask periodically that we put the room lights on, because if you're going to sit there and not do anything, you're going to get very sleepy, especially if the lights are off. Okay? So, let's talk a little bit now, thank you so much, and we'll bring them back down in a moment. Okay, let's talk a little bit about the importance of the scleral spur physiologically, anatomically. It's okay? All right. Let's go through the word dialysis. If I were to say to a person, I need to put a patient in renal failure on dialysis, what do I mean? I mean I am separating out blood components. So in general, the word dialysis means a separation. So let's define, what do I mean by iridodialysis? The iris separates from what? From the iris root, from its insertion into the iris root. It's okay? Okay. Now, here's what I want you to do. And if you are good-natured, you will do this with me. I have to tell you that if you will do this will seem to be very foolish, but if you will do it with me, you will learn a little bit about ophthalmic pathology. So let me give you an example. Okay, you ready? I need to say goodbye to my boss. He is the president of the university. I work for him. Okay, enjoy your trip. They're going to do some tourism in the Galil, so I hope they have a pleasant afternoon. All right, for the rest of you who are still here, okay? Can you extend your arm like this? Yeah? Okay, very good. We're going to pretend now that the elbow is the ora serrata. Yeah. So put the retina onto the ora serrata like this. Now I must tell you that if this were an infant eye, and you fix the eye in formula, and the vitreous base contracts, and you make like this a fold. Okay, you make it? Yeah. Mm-hmm. As you make it, you can say out loud, Lang's fold. Nobody said, yeah? One more time. Well, Lang's fold. Lang's fold. Yeah. Lang's fold. When you see a Lang's fold, you can tell, and only histologically, you never see this ophthalmoscopically. When you see this, you will say to yourself, this is an infant eye. Very important. We'll come back to this topic again. Okay? Can you make for me again the ora serrata and the neurosensory retina? Yeah? Now, you show me, what is a retinal dialysis? What happens in a retinal dialysis? If it separates. Yeah, again, like this. Yeah, right. Very good. You want to get more complicated with the yoga positions? Do another yoga position here. Okay. So the way I'm going to do this now is to take your arm like this, your left arm, and put out your wrist and make a curve. We're going to pretend that the wrist is a scleral spur. And into the scleral spur, I want you to insert the ciliary muscle. You make the iris. It's a little bit awkward. It's okay? All right, now, let's accumulate fluid between the sclera and the ciliary muscle. When that happens, and by the way, there's a name for it, it's called a choroidal effusion. A ciliochoroidal effusion. If you put fluid between there, look what happens. The ciliary body will rock like a door and a hinge. Does it make sense? Clinically, what happens to the depth of the anterior chamber in a choroidal effusion? It becomes shallow. You see. Now, let's do one more thing. The ciliary body is a circle. Another name for a circle, if you're breaking in Greek, is cycle. So if you have a cyclodialysis, then you have separation of the ciliary body from the scleral spur. It's okay? Got it? So show me now, what is a cyclodialysis? So first, let's put it together, the parts. You put together the parts. Now show me, what is a cyclodialysis? What happens when it separates? Now the reason it becomes important is that when you're doing gonioscopy, You come in, you see this little spur. Posterior to this little spur, you see additional sclera. What color is the sclera?